They were doing a live question and answer for um, issues related to hyperparathyroidism, how to diagnose it, how to treat it, what's the next step, what conundrum you're in, how how challenging the system is making you getting to your diagnosis and treatment, all common problems that people with hyperparathyroidism face, unfortunately. A very much an orphan disease in my mind. In any case, we have a long list of questions, so let me go ahead and start. Um, so, first question is from Maggie MC. Dear Dr. Larian, thank you for taking my question. My pleasure, Maggie. I have over 2 years of documented blood test results that consistently show borderline high normal calcium and high to high normal PTH levels, indicating an abnormal relationship between the two. Fantastic. So you understand the fact that when calcium goes up, PTH should go down normally, and when calcium goes down, PTH should go up. So this relationship should be inverse of each other, and yours is clearly not. You have a high normal calcium and a high normal or elevated PTH, and that's abnormal, right? All right. I have many symptoms affecting my daily life, also diagnosed with osteoporosis and chondrocalcinosis. I underwent gastric bypass surgery 17 years ago. I understand this may sometimes affect labs results, but I've never had deficiencies in vitamins or minerals except for vitamin D, which I supplement. Maggie, it would be very helpful to see actually your numbers, calcium, PTH, vitamin D levels, if you have 24-hour urine calcium. In the setting of normal calcemic hyperparathyroidism, what we have is elevated PTH numbers, right? And so we really need to make sure we look at all these other possibilities, right? So we need to make sure your vitamin D is corrected. So looking at your labs to make sure your supplements are correcting your vitamin D, because that could cause an elevation in PTH. A 24-hour urine calcium can tell us if you're having calcium absorption issues. Usually your calcium would be low in the bloodstream, not high, so that magnesium can affect it. So low magnesium, renal calcium leak, and that would be hypercalciuria, which means on the 24-hour urine calcium, your calcium would be too high in the kidneys. Kidney malfunction, malabsorption, so celiac disease, which is the true autoimmune gluten intolerance, which this is the test for it, and these medications, to make sure you're not on any of these medications, because these could affect it. So all of that information would be very helpful to figure out if you have a secondary elevation in PTH, not caused by hyperparathyroidism. And that's the process I go to for all my patients with hyperparathyroidism or with normal calcemic hyperparathyroidism, where the calcium is normal, PTH is elevated. I gotta rule out all the other things that secondarily can elevate PTH, and that's what you should do as well. But having said that, let's assume that you've done that. I'll go on with your questions. It is difficult to find a doctor who will treat my normal hyperparathyroidism, particularly when my last two blood tests, while still showing an abnormal calcium PTH relationship, are lower levels than before. Why would this happen? Can hyperparathyroidism go away? Thank you in advance. Well, again, first you need to rule out these causes. This one is, you do have to check your 125 hydroxyvitamin D levels, because sometimes you're not making enough in a kidney, and that's a kidney issue and can be rectified by taking this. Or some people, as we get older, our intestines become resistant to activated vitamin D, right? And you have to have higher doses in order to get the job done. And in the parathyroid system, the most important job vitamin D does is it helps you absorb more calcium from your food. So instead of 20% absorption of calcium from your diet, you get 80% with vitamin D being present. And that's a huge difference, right? So let's say you've ruled all of this out and you still can't get a doctor to pay attention to you. the reason for that is the reason for it is a series of studies done by Professor Jens Bollerslev, in which he looked at people who had minor elevations in calcium. So they had hyperparathyroidism, they had a slight elevation in calcium, and looked at them over a 2-year period, right? And they had, I think, close to 120 patients, or 191 patients, right, who showed up to these hospitals, to the Nordic countries. I think it was Norway, Sweden, and Denmark, I believe. And they randomized them to surgery and non-surgery, and they followed them up with questionnaires, and over a several year period, right, over a 2-year period, and these were quality of life surveys, and they found that in the non-surgery group versus the surgery group, their quality of life did not seem any different, right? And interestingly, they found that all of them had improvement in their bone density. Even if their bone density was not bad, they still had improvement. So in your case, when you have osteoporosis, it should be a no-brainer that this should be treated. I think that's the angle you have to go. You have to go to them and say, I have osteoporosis, right? And I have an imbalance in my parathyroid system. Explain to me why my calcium and PTH don't follow this relationship, right? And I'll show you the graph that calcium and PTH should follow in a normal person, right? And what you may want to do is actually directly go to a parathyroid surgeon instead of just sitting with your primary doctor or an endocrinologist, and see if they can look into it in more detail and proceed. Now, these studies by Professor Bollerslev made people pause and say, well, if you're not feeling better at 2 years, if you have surgery or not, if you're feeling the same, then what's the point of surgery? Well, improving your bone density in and of itself is a meaningful thing if you have osteoporosis, right? But what if you didn't have osteoporosis? Do you still do nothing? I feel that Dr. Bollerslev's study was important because it did show that if you just have all comers with hyperparathyroidism and you randomize them to surgery or not, you may not get an improvement. But I feel like when I look at this study that they weren't really separating people who had absolutely no symptoms versus people who had symptoms that were affecting their quality of life to begin with, right? And then randomizing those people with symptoms who had quality of life issues to surgery and non-surgery and compare those two at 2 years. I think that would have been a more meaningful study. And the third arm would be the non-symptomatic ones, right? And comparing these three groups, I think that would be a very meaningful thing to do, right? Because I think that would have given us more information and then let us know symptoms versus non-symptoms. What do you do, right? Because that's really the big question in hyperparathyroidism. What do you do with someone who's truly asymptomatic? They absolutely have none of the symptoms, right? They don't have any of these symptoms that are affecting the quality of their existence, right? And I think what we need to do is figure out what, let's say, if someone has a minimum of 2 symptoms, right? And let's see, thirst and fatigue, for example, right? Or what combination of symptoms should you engage because you will have improvement, right? We need more detailed studies to figure out all of this information. Okay, so I think that's really an important thing that we still don't have yet. But it wasn't included in that study, and so we're kind of lost. And then the graph I was suggesting is this graph. So every single one of us has this graph. This is relationship of calcium versus PTH. Dr. Struller, who was brilliant, in 2005 described this relationship, and everybody has their own graph. This person has a graph that has a set point, a calcium set point of 9.5, right? My calcium set point may be 8.6, in which case my graph would look like this. And someone else may have a calcium set point that's at 10, right? And their graph would look like that. So even with someone who has a calcium set point of 10, meaning high normal, this green box is high normal. Even in this individual, if their calcium goes to 10.2, their PTH drops to be on the low side. And if their calcium goes to 9.8, their PTH would be high, right? So that's why looking at multiple numbers and graphing it out will tell you, because if in your particular case, Maggie, if you have certain points when your calcium is, let's say, at the upper limit of normal and your PTH really drops low, that just means you have a graph that's following this black graph here, right? And that's your particular flavor of normal, okay? And so it's important that you set these numbers. I think it's also important that you show your doctor this particular graph and this explanation, and maybe have this article pulled up, which was in JAMA in 2005, which describes these graphs. And show it to your doctor and have them explain to you how they think you don't have hyperparathyroidism, right? And how to exclude it out. It's a very difficult thing, but you have to be forceful. You know, this when you don't have clear numbers, when you have unusual presentations, right? When you don't have either high calciums or high PTH, you know, you don't have the combination of a high calcium and a high PTH together, clear high numbers, then it's a struggle with you against your doctor, right? Because when your doctor looks at your numbers, an inexperienced doctor looks at your numbers and sees that your calcium is in the normal range, sometimes they may, because they don't understand, dismiss you and say, well, that's normal, let's just sit and wait, right? Sit and wait while you have osteoporosis and are losing more calcium through your bones, and that's not acceptable. So you got to keep pushing. One of the problems with hyperparathyroidism is that it creates a lot of anxiety, and then you know your brain is not working perfectly well. Even though you know you can do things and make sense of things, it's not running efficiently. So you may at times seem irritable and agitated, yeah? You know, and you go to the doctor's office and you bring all your stuff, you come in cool, calm and collected, and then you present your case, and the doctor's just saying no, and at some point you're going to lose your cool because you're feeling awful, right? And their doctor is not acknowledging the fact you're feeling awful and dismissing you, and then at some point you're going to lose your cool and not be as cool as you can be, and then it makes it even easier for the doctor to say you're insane, right? You're neurotic, you're fixated on something that's not real, and dismiss you even more, right? So I would say be cool. If they're not listening to you, and they're not going to listen to you if you raise your voice, right? If you get and it's, again, when you have this condition and you feel ill, it's easy to get to that point of frustration, and I don't blame you for getting there. It's just that when you have doctors that are not responsive or don't understand this disease, they will use that as an excuse to not address it even more. So be organized, draw the tables. You may want to download this from my website. This is a worksheet that has your symptom list here. You can fill in your labs, put in the dates, explain to them hypercalcemic, normocalcemic, normal hormonal, hyperparathyroidism, and then all the workup necessary. You can write notes in here. You can go in prepared and push, and so they can see that you're organized, you have everything in order, and you're not being neurotic. You are looking at the trends of your calcium and PTH numbers, and they're not making sense to you. All right, and you're feeling it. And look at the list of symptoms that I have. You know, right? I have this many symptoms. These are my labs, and so on and so forth. Okay, I think that's one of the better ways to approach it. Good luck, my dear. Sometimes seeing a parathyroid surgeon helps because they may, when you go directly to them, they're not beholden to the endocrinologist. They may just treat you as the person who comes in. All right, so I just got a message from Nancy Lindsay. A few of us were waiting on Facebook. Just learned that live is already taking place here. Hello. Hi, Nancy. Hello. I mean, I'm trying a new way of doing this so that it's available both on Facebook and YouTube. So for people who don't have Facebook accounts, they can access it through YouTube without an account. So hopefully this will help. Anyways, moving on. Joanne Roper. Hi, Dr. Larian. Do you think malabsorption like autoimmune atrophic gastritis could cause hyperparathyroidism? Yes, I do, because it may cause secondary hyperparathyroidism, right? Not primary, and it'll do it by not allowing you to absorb either calcium or vitamin D. I had a B12 of 2.7 years ago and iron deficiency. I understand, but D gets knocked down as well. 2 years later, my calcium started to rise, but my doctor ignored it for 8 years, and I finally diagnosed myself with parathyroid adenoma. This affects your ability to make hydrochloric acid, so you can't absorb iron or many bits and minerals, especially fat soluble. So if you're low in vitamin D and therefore not getting calcium, your PTH will draw from your bones, hence the high calcium. Just wondering about your thoughts on this. So I am not a big believer in non-kidney failure related secondary hyperparathyroidism that causes elevations in both calcium and PTH. By that I mean, if you have malabsorption where you're not absorbing vitamin D, let's go back to this, okay? So this is the parathyroid system, okay? So if you have malabsorption and you're not absorbing vitamin D, all right, that means you have low vitamin D, activated vitamin D, which means that you're not getting this, right? So the absorption of calcium in your intestine is at 20%, because with vitamin D it goes up to 80%. So you're absorbing 20% of the calcium, right? So you have less calcium absorption, right? And so when your calcium in your bloodstream goes down, you have increased PTH, right? Increased PTH goes to your bones and tells it to leak out calcium, so it leads to osteoporosis in the long term, right? And this calcium comes out, right, into your bloodstream and brings your calcium back up again. It is hard to imagine that when your calcium gets to your normal levels, because it's leaking out of your bones, that you're going to have a persistent elevation in PTH, so much so that it causes further bone loss, right, to the point that your calcium is above the level you want. So by that I mean, okay, let's say you have a normal functioning parathyroid gland, right, that's set for a calcium of 9.0. Range of normal is 8.8 to 10.2, okay? So you're set for 9.0, okay? When your calcium is normally, this is in a normal parathyroid environment, if your calcium goes low to 8.8, you increase calcium production, PTH production. PTH goes to your bones, tells your bones, release calcium into the bloodstream, right? And as your calcium goes up and up, once it reaches the 9.0, your PTH production goes back to the baseline, right? If you overshoot and go to 9.3, your PTH production goes lower and lower. And this stops, right? Now, if you have malabsorption of vitamin D and calcium, so your calcium, now you have less absorption of calcium and you have less vitamin D, your calcium goes down again, right? It goes really low. It goes to, let's say, 8.0. And your PTH production goes higher and higher, right? Now you have really high PTHs because your calcium is so low. And you get a lot more calcium coming out of your bones, right? Once your calcium reaches 9.0, your PTH should go down, right? And if it goes to 10.2, really high numbers, your PTH number should be extremely low, right? So I don't believe that when you have vitamin D malabsorption, you're going to get so much PTH that it's going to rise up your calcium way above normal, right? It can be somewhere in the normal range. It can even reach the middle of normal. But I can't see how that could cause vitamin D deficiency, can cause massive increases in calcium, right? Because you're not absorbing calcium, your vitamin D is low, right? Yes, you may have high PTHs and you may lose calcium through your bone, but your parathyroids are set for a certain calcium number. That hasn't changed, right? You have secondary hyperparathyroidism, meaning your parathyroid glands are not abnormal, they're just reacting to low vitamin D and low calcium. But they're still set genetically for the same number, right? Whatever number that is that we saw here, whatever number you're set for here, 9.5, that setting doesn't change, right? So your vitamin Ds are low, your calcium absorption is low, so your calcium goes down and your PTH will go up, right? That's fine, that's normal, right? But this graph doesn't change. This graph stays the same, right? And no matter what you do, this graph stays the same until you have kidney failure for years and years, so that your parathyroid glands are working harder and harder and harder and getting bigger and bigger and duplicating themselves until they get mutations in them, and then they no longer are connected to this graph. They now are at a higher graph that takes over the system hostage, and then that's called tertiary, where they've changed graphs and they're no longer, right? Once you have tertiary, you have most likely a hyperplasia in all four glands, or adenomas, multiple adenomas, and so on and so forth. In any case, so I am not a big believer that vitamin D deficiency in and of itself can cause high calcium levels because you have higher PTH. It can cause normal, it can follow this graph, right? But it can't create its own graph unless you get to tertiary hyperparathyroidism, which is after way prolonged secondary hyperparathyroidism is in place, okay? And so I think that's where it is. So if you have high calciums and a high PTH, right, and have malabsorption, and you can't absorb vitamin D, right, take sublingual drops of vitamin D, right, that should absorb because it's not going through your intestines, right? If even despite that, you can't get your calcium up because your intestines are not absorbing the calcium still, because you have intestinal issues, you got gastric bypass, or you had intestinal surgery that now you don't absorb things, then you're forced to get calcium in other ways, either intravenously and so on and so forth, right? Doing something to the parathyroids is not going to correct the problem, okay? And then Sean Moss asks, What causes tertiary hyperparathyroidism? Could it be persistent low? It is persistent low vitamin D that causes tertiary, but it usually is in the setting of kidney failure, right? Because it's the kidney that has this enzyme that changes inactive vitamin D, the one that you take as a supplement or is made by sun in your skin, to the active form, right? If your kidney fails, this enzyme is not there, you're not making this. And if you're not making this, your calcium absorption in your intestines is low at 20%, and you don't get depression of PTH, and your glands are parathyroid growth, right? You don't get suppression of parathyroid, so the parathyroid glands grow and grow and grow and grow, all of them, and they produce more and more PTH, right? And because your kidney is not filtering it appropriately, your calcium numbers go up, your PTH numbers go up, and over time, as these glands are overworking, at some point, they'll get mutations in them, and they'll get multiple adenomas in them, right? And they'll start getting, these adenomas will have higher settings for calcium, and then that's tertiary. Tertiary is when the parathyroid glands have changed their calcium setting from, let's say, a 9.5 like our graph showed, to an 11.2 roughly, averaging up the different adenomas and what they want, and your parathyroids are now trying to get you to this number, and they just keep producing PTH, right? And that's tertiary. Can tertiary happen if you don't have vitamin D for a long time? It's conceivable, right? If you have a vitamin D of 3 for 20 years, then yeah, this can happen. This will happen, right? But if you have it for that long, you're gonna have so many other issues, right? Probably way before you get to this stage, you're gonna be very ill before you get to this stage. So you would manifest. All right, so let me move on to the next question. Joanne, thank you for your question. Esther Rollins, hi Esther, good to hear from you again. What can I do about my slightly low phosphorus? I know there's an inverse connection with calcium. I'm doing the watchful waiting for 5 years now. Everything's going well, but I was wondering if it's important to do something about the low levels, only slightly low and sometimes within range. Esther, it's a good question. If it's slightly low, I mean, if you have hyperparathyroidism, in the kidney, there's a calcium phosphorus exchange mechanism, right? So calcium goes in and phosphorus comes out, right? So if you have hyperparathyroidism and in the kidney, the PTH is telling your kidney, get the calcium back from the urine, that means the phosphorus is being let go, right, in exchange. And so you have a low phosphorus level in the body, right? And if it's minimal and mild, it's not an issue. But if it gets to be more severe, then you may have symptoms of hypophosphatemia, in which case you may have to take phosphate supplements to correct that. And then there's medications and so on that can be done. But you need to see really an endocrinologist or a nephrologist to help you with that. Now, if you have chronic low phosphates and you have hyperparathyroidism, please look at the symptoms, look at your bone density, and decide if you need to, instead of waiting and watching, you need to address that. All right, Esther? Hopefully this is helpful. Maggie Bradbury. I was just wondering what is the best calcium supplement to take. It is my surgeon's preference to take Tums or citrate. I prefer calcium citrate. I actually feel like calcium citrate is easier on my patients' intestines. So I give them Citracal, which is calcium citrate. I give the Citracal Petites, and I follow this chart, which is based on preoperative calcium, how much calcium to take. Daily, I also give patients magnesium. This has vitamin D in it, so it's both calcium and vitamin D. All right. but I also give magnesium, which helps stabilize the calcium sensing receptor. Um, and so that's my part. I don't like Tums, um, because I actually want to have vitamin D in there. The Citrical D does have vitamin D in it, um, and I feel like there's a lot more stuff in the Tums that I just don't want to. I don't want to expose my patients to. Whereas I find the calcium citrate to be easier on my patients in that recovery period. All of the citrate supplements that I have researched have magnesium in them. From what I know, you shouldn't take magnesium and calcium together. They fight for absorption. Uh, they have magnesium, but the magnesium in them is so small that it doesn't outcompete the calcium, right? So and then Maggie has written, I was also told that calcium citrate doesn't have enough elemental calcium. Enough, I don't know what enough means, right? By that I mean, I found that when I have my patients follow this regimen, great majority of patients with hyperparathyroidism have a calcium that falls in this range, right? And it's a minority nowadays that get these higher numbers, right? And so I found that not close to 95% of the patients that I put on this regimen, they don't get symptoms of low calcium, right? So I am able to give enough calcium pills to overcome the malabsorption or hypoabsorption issues, right? Or not. And I think the magnesium that's in there is not an issue. I do have my patients take magnesium twice a day, right? And that does help with making the calcium rebalancing a little bit smoother. So, not necessarily take it at the same time. And I try to have my patients divide this morning dose into 4 pills at, let's say, 8 a.m. and 4 pills at 9 a.m. For better absorption of the calcium citrate, and have the magnesium be somewhat apart. In any case, these are good concerns, but I think you're okay with the calcium citrates, okay? Janice Heffernan Warnament. I had 3 parathyroids removed in 2018. Unknown location of the 4th, my 2024 lapse, calcium 10.7, PT 73. So both are elevated. Due for blood work next month, no parathyroid family history, thyroid cancer family history. Your recent post-read genetic testing, can you tell me what the results could reveal to help with treatment options for hyperparathyroid, hypercalcemia, FHH? Well, Janice, if you had 3 glands removed, more than likely what it means is that instead of having 3 separate adenomas, right, that they removed, that you had hyperplasia, which means all of the cells in all of the glands were abnormal, right? They couldn't find one of them. Let's say they couldn't find this one, right? Because it was in an unusual location, okay? Maybe it was ectopic and all the way down in the chest somewhere, all right? So they took these 3 out. That one was still abnormal, right? And it took between 2018 and probably somewhere in the early 2020s or 2023, for your labs to show themselves. And if you look at the numbers, they were probably tracking upward. So you had hyperplasia, and the 4th hyperplastic gland is missing, right? Genetic testing isn't actually going to help your hyperparathyroidism. It may identify if you have an MEN syndrome, right? Let me bring that up. I have so many slides, yeah. It'll identify if you have MEN syndrome, right? In which case you have to look at your pituitary gland and pancreas, right? Or look in the thyroid for thyroid cancer or these hormone producing tumors, right? And for you, it won't help the hyperparathyroidism, but it will help identify if there's other issues, right? There are 9 genetic diseases that cause hyperparathyroidism that we know of today. And if you do the genetic testing and you find that you have one of those 9, then you can tell your siblings, your children, your parents, family members that this gene exists in your family line and that they should look for it and look for the diseases that may be associated with them. For example, if you have MEN2A, which is caused by the RET proto-oncogene, right? If you have this particular mutation, then you're very much prone to having thyroid, this particular unusual thyroid cancer, 98% do. In which case, you can let your family members, your children know so that they can be monitoring their thyroid gland and checking for the hormones of this particular type of thyroid cancer. This is the only type of thyroid cancer that produces hormone, right? Calcitonin. Have them check for that particular hormone regularly and so on. So the genetic testing helps you in that regards, okay? It won't help you treat the hyperparathyroidism because we already know you have hyperplasia, right? Genetic testing will not tell you anything different, right? So what you need to do at this point is to do an ultrasound, preferably done by a parathyroid surgeon so they can look at the surgical areas and see if they can find it. If that doesn't show the 4th parathyroid, then a 4D parathyroid CT scan. If that doesn't show it, then I would, in that scenario, do a sestamibi, even though I don't think a sestamibi at a PTH of 73 is going to really show you much, right? When the PTH is less than 150, it's not quite so accurate, right? But I would do it in that scenario just in case. And if that all fails, then I would do a PET choline scan. PET choline scan is the latest and greatest that may show you, like in this person, they shows it in their chest. So this is this person's chin, neck, chest, back of the neck, shoulders and back, and this is showing a parathyroid right there, which is what's lighting up right there. In the frontal view, this is where the parathyroid is in the chest. Okay, so that's my suggestion for you. Okay, Nancy, yeah, okay. Maggie Bradbury poses a good question about calcium following surgery. Some of us prefer calcium citrate over carbonate to deal with constipation. If our surgeon stipulates Tums, can we substitute the same milligram? Yes, you can. Yes, you can. I would just follow that chart that I showed, right? And maybe share the chart with your surgeon, right? And say, hey, this is one thing we found. What do you think about it, right? But yes, I would. I find that people who take too much calcium actually get intestinal issues when they take too much Tums. I mean, if you take too much calcium, also you can get there, but too much Tums, more likely to get intestinal symptoms. Kelly Camp. I had a surgery in 2023, 1 parathyroid removed. My labs were normal after that surgery for some time. I currently have symptoms again, normal vitamin D, slightly high PTH to normal, 45 to 75, normal calcium, normal iodized calcium, low phosphate to normal, high calcium in the urine. That's interesting. So you have now, let's see, a picture that looks like a normal calcemic hyperparathyroidism. Your calciums are in the normal range. Your PTH can be high or it can be in the normal range, right? But your 24-hour urine calcium is elevated, which tells me that your kidney recognizes your calciums, even though they're in the normal range, to be too high. That's important, right? Taking vitamin D makes me very unwell. That makes sense, because if you have high PTHs, right, if your PTH is high, then vitamin D gets activated into this active form that goes on and does all sorts of things in the body. And sometimes when people have elevated calcitriol, which is not normally tested on blood tests, they're going to get symptomatic. That's another sign that you're having hyperparathyroidism. Can you explain, is the phosphorus levels to tell of primary or secondary? When the phosphorus is low, it's more indicative of a hyperparathyroid state. Not necessarily primary or secondary, but it's the hyperparathyroid state. And how do distinguish urine calcium leak from a parathyroid issue, primary or second? Okay, so when you have a high 24-hour urine calcium, right, and you get concerned about renal calcium leak, right? You have hypercalciuria, right? Your PTH elevated, just like yours is, and this is a genetic condition, and you've had it all your life. So you would have had always PTH elevations, and it wouldn't have normalized when you had your surgery before. So you said your labs were normal for a while, which means your PTH came down, but if you had renal calcium leak, that wouldn't have happened. You have persistently had PTHs that stayed high, because if you had renal calcium leak and a parathyroid adenoma, when you remove the adenoma, right, this condition would persist because this is in the kidney, right? In the kidney area. And so you would have had normalized labs. So I don't think you have renal calcium leak in your particular case. For a person who comes to me fresh and they have normal calciums and high PTH, renal calcium leak is one of the considerations. And that's why I would, if you have normal calcium levels like you do, and your 24-hour calcium is high, and you came with a high PTH, and you didn't have the history of previous surgery or anything like that, and normalization of labs, then I would treat you with hydrochlorothiazide, right? So I don't think at this point you have renal calcium leak. I think you have probably recurrent hyperparathyroidism. I would have to look at more trending of your labs and what the numbers are doing with each other to give you a better answer. But it seems to me you have a recurrence. Nancy Lindsay. Hi, Nancy. My questions are very personal and specific, but they're at their base, I think they apply to all of us. 1, should ionized or serum calcium be used to diagnose primary hyperparathyroidism? I like your personal questions, so let's talk about that, right? Let me get the right, okay, so calcium in your blood vessel. So this is a blood vessel, right? The calcium that's in your blood can be in its free-floating form, right? That's the free calcium. Or it can be attached. It can be attached to proteins. It can be attached to phosphate. It can be attached to citrate, right? This attached form of calcium is not available for use. So it's this free calcium that is useful calcium, okay? So in this picture here, there are 22 calciums, attached and free, okay? In this one, there's also 22 calciums, but the number of free calciums is much higher than this one. If you look at a total calcium, both of them would have the same number, right? But if you look at the free calcium, this one would have a high calcium. This person is hypercalcemic, even though their total calcium number is the same, right, and maybe normal. Okay, so maybe the calcium for both of these are 9.8 and 9.8, but the ionized calcium and this one is normal, while this one, the ionized or free calcium, is elevated. Okay, so that can help, but I think the more important thing is the relationship between calcium and PTH and how those two functions, right? And the problem with free calcium testing is that the machine that tests for free calcium has to be calibrated very frequently to give you accurate numbers. And in the hospitals, they use that machines in for surgeries, and anesthesiologists use it all the time during surgery to check the person's free calcium to see if it needs to be replaced. They also check it in the emergency room when people are having, emergencies in the hospital, heart, cardiac arrests or anything like that. You need to immediately get a calcium number and see if you need to replace the calcium, because that'll make the difference of being able to recover a patient whose heart has stopped or not. So these machines are constantly being used in hospitals, right? The busier the hospital, the better, and they're constantly getting calibrated, right? And so the numbers are more accurate. In a freestanding lab, they're not being used so much, so I don't trust those numbers quite as much, which limits you as a patient, because if you go to one of the labs, Quest, LabCorp, one of these, labs that have branches all around the country, you may not get an accurate ionized or free calcium number. All right, Nancy goes on. I've been diagnosed with recurrent primary hyperparathyroidism based on serum calcium, parathyroid hormone, and vitamin D. My serum calciums are in high normal range, while my PTH is above normal range and vitamin D is normal. My ionized calcium has only ever been checked 2 times, both in an emergency room setting. Great. I did not have a serious medical condition at either of those times. The first ionized calcium was somewhat below the standard range, and the second was at the very bottom of the standard range. This apparent discrepancy between my ionized calcium levels is prompting me to have both ionized and serum calcium tested in a single draw with PTH on it. This shows relatively low ionized and relatively high total. Well, that in this scenario, ionized calcium is exceedingly helpful, right? Because you actually have low calcium levels and you have a secondary high PTH, which is appropriate, right? So this is the scenario where the ionized calcium really, really helps. And when do you get a normal or high normal calcium, a 9.8, but low ionized calcium? When you have either too much citrate, too much phosphate, or too many albumins, right? So if there was one more albumin here, or 2 more albumins here, right, then the number of free calciums would be very limited. And this person has really low free calcium and free available calcium, right? But their total calcium number is normal. So free calcium really helps in this scenario, okay? So you may not have primary hyperparathyroidism there, you may have secondary, okay? For optimal results from parathyroid testing, what drugs and supplements should be stopped and for how long before? Okay, so she's taking thiazide diuretic. That should be stopped for 2 weeks. Then the other things that affect it is biotin, right? So Nancy is taking biotin as well, right? Biotin interferes with the machine. It doesn't cause you to have low PTH numbers. It just interferes with the machine that checks PTH. It attaches to components of that machine that gives you a false low PTH, right? So biotin should be stopped. They say 3 days. I ask my patients to do it a week before. I haven't read anywhere that spironolactone, which is also a diuretic of sorts, it affects calcium. But I would stop that for a week also. Let me look up the half-life of spironolactone. Yeah, I would stop the spironolactone. Let's see. Yeah, spironolactone has a very short half-life, so 3 days before. I would stop it. Yeah, I would stop the spironolactone. I would stop the thiazide diuretic, and I would stop biotin. Okay, and those will give you more accurate numbers. Very good question. All right, moving on to more of your personal questions. I expect to continue taking these medications and supplements for the rest of my life. So whatever effects they may have on my calcium parathyroid will continue. Yes, but you want to come off of them, right, to see what your numbers are doing while you're off of them. If your numbers normalize and they're okay, then you can go back on your medications and supplement appropriately to diminish the impact they have on your parathyroid system. By the way, I was required to withhold spironolactone for 6 weeks prior to selective venous sampling to locate a malfunctioning parathyroid gland, but told to continue the thiazide. Yeah, that doesn't make sense. And 6 weeks is way too long. Half-life of spironolactone on the Google search is 1.4 hours. In 7 half-lives, more than 99% of the material goes away. So 6 weeks is way too long to have an impact. All right. But spironolactone has a metabolite actually. You know, some of the metabolites of spironolactone have a 15-hour half-life, so I would say I would stop it. I would stop it, the spironolactone, maybe 5 days before doing the labs, because then you'll get rid of all the metabolites too, but not 5 weeks. All right. Thank you for making me think, Lindsay, but continuing. And then Nancy says, as a patient, these questions feel like they're above my pay grade. Shouldn't my medical professional be taking care of these matters? Yes. I've also learned on my own that these blood draws should always be taken first thing in the morning after fasting for 12 hours, and that I might need to ask some questions to try to be sure that the draw for ionized calcium is taken and handled properly, all while I'm struggling with brain fog and depression. Yes, you are correct. Blood tests for hyperparathyroidism should be done fasting and at 8 o'clock in the morning. 12 hours I don't think is that crucial, but if you're doing the blood test at 8 a.m., unless you live in Spain and are eating at 11 o'clock at night, which even in Spain doesn't happen regularly, right? Most of the time you're having dinner, and it's about 12 hours by 8 o'clock when you come do it, yeah. But yes, don't do it earlier than 8 o'clock or much later. There's natural elevations in PTH at 6 a.m., 10 a.m., and sometime in the afternoon. 8 a.m. is a sweet spot where you can, somewhere between 7:30 and 8:30, where you can get a more accurate view. You don't get a false elevation in PTH, okay? Thanks, Nancy. Good luck. I'm 59-year-old. This is Helena Saloma. I'm a 59-year-old Finnish woman and wondering, could I have normal calcium hyperparathyroidism? Latest lab results with Finnish reference values. Thank you for putting that in. Calcium ionized is 1.28. The upper limit of normal is 1.3. PTH is 84. The upper limit of normal over there is 85. Magnesium is, so your calcium is in the upper limit of normal. If the screen is the range of normal, your calcium is on the upper limit of normal, and your PTH is on the upper limit of normal. Now that's inappropriate because they should be inversing, right? Magnesium is normal, phosphate is normal, vitamin D is healthy and in the normal range, so you don't have secondary hyperparathyroidism. 24-hour calcium is 1.79, which is a little bit lower than normal, but it's not dramatically low. Okay, sometimes I see this phenomenon in patients because PTH goes to the kidney and tells the kidneys, get the calcium back, right? So sometimes when the calcium number in your bloodstream is not overwhelmingly high, this PTH absorbs a lot of that calcium that's trying to leak out of your kidney and get it back. So you may have a slight diminished 24-hour urine calcium, okay? Alkaline phosphatase normal, creatinine is normal, GFR is low, so your kidney's getting affected, and serum calcium is in the middle range of normal, if no ionized calcium. So it looks to me that you have hyperparathyroidism. Yes, it looks to me, I agree, that you have normal calcium hyperparathyroidism. However, under the contradiction, the calcium in the urine is clearly below the reference value. In 2014, they found an adenoma in my hypophysis. And because of that, I was thinking I have MEN1 syndrome. Could something else explain the contradiction? Well, yes, you may have an MEN1 syndrome, just like we talked about earlier. Because with MEN1, you get pituitary tumors. So if you had a tumor, you should do genetic testing to check for MEN1. And I just explained why your 24-hour urine calcium can be low when your blood calcium numbers are not significantly elevated, okay? I've been having symptoms over 10 years, and I've been seeing symptoms over and they have been getting worse over the years. This past year particularly has been awful. My symptoms cover fatigue, insomnia, cognitive problems, lack of concentration, memory loss, brain fog, bone ache, osteoarthritis, changes in the bone structure, osteoporosis. I was diagnosed with osteoporosis in 2024, and I've been on HRT since 2017. I'm suffering from stomach problems like nausea. Sweetheart, you're just going through my list of symptoms. All right? So, let's see. Fatigue, concentration issues, memory problems, brain fog, bone pain, nausea, dyspepsia, so you also have chest pain, which probably comes from acid reflux, and you have palpitations, which didn't even make it in the list, but it's a common problem, right? atrial fibrillation, which can be caused by this. Yes. So yes, dear, you have normal calcemic hyperparathyroidism with lots of symptoms. And I do suggest that as part of this, that you do look at let's find a chart for you. All right, so this is the chart. You do have a little bit of a decreased kidney function, right? It's not below 60, so but you should see a kidney specialist and look at that and see what's going on. So definitely see a kidney doctor, right? You don't have renal calcium leak because your 24-hour urine calcium is low, so this is not part of it. Your vitamin D is normal, that's not part of it. I don't think you have low calcium intake because your serum calcium is not low. Your magnesium is normal, so you don't have that. You can check for malabsorption by doing this blood test, and you have to make sure you're not taking any of these medications, which can give you a false elevation in PTH, right? So most of the work you've already done, right? The only thing you need to confirm is kidney function, malabsorption issues, and see a kidney specialist to check your kidney. Why is your kidney function low? Barring all of that, it looks like you have normal calcium hyperparathyroidism and should get it treated. I think if you get a kidney doctor involved, right, and they can see why, what other reason you may have for diminished kidney function, then they can force the issue of treating your hyperparathyroidism even though it's normal calcemic, okay? And if you have any more questions, please don't hesitate to contact me. I know this is complicated. Good luck, my dear. Sherry Joyce Johnson, thank you. It's been quite the journey for me, but having surgery in December, I will be tuning in. Sherry, good luck with your surgery. Please share with us. I highly suggest that you get a list of symptoms, all right? I don't know if I have my questionnaire in here. Maybe I'll put my questionnaire on there. Oh, actually, hold on. Let's see. This is it. This is my questionnaire. So this is the questionnaire. If you would take a picture of this thing and rate your symptoms, right? Anyways, and then let us know what your labs were before surgery, what your labs are after surgery, maybe 6 months after surgery. Share your experience with everybody else so that everybody knows what you're going through, right? And how you've recovered. Because, you know, it's one thing for me to keep saying it, but it is really more important when a patient who's going through this experience shares their experience and everybody knows the reality. And it's a wide range of recoveries. You know, some people feel like $1 million immediately right away. That's a rare person. I wish it was the common finding, but a lot of people have gradual improvement of symptoms. And just all of you, if you're having treatment, share with us what your experience is, so people have a realistic view of what to expect. That way they can make a decision for surgery that's more appropriate for them. All right. Anyways, good luck again, Sherry. Candice Kleitz-Witzel, I'm finally getting the nuclear medicine scan tomorrow. Good luck. And then Lansing says, don't be overly concerned if it shows nothing, especially if it's for a first parathyroid surgery. The best PT surgeon can manage well without clear localization. Yes, but the nuclear scan is my last choice. Ultrasound is my first. So ultrasound is my sorry. So ultrasound is the first choice, 4D CT scan is the second choice, and SESTEM-EB is my third choice in scans. And then in recurrent cases, I do the PET calling. So, Candy, you're doing my third choice. Hopefully, you've done number 1 and 2. They're more likely to show something. Okay? Bridget Nazarian, thank you. My pleasure, Bridget. Maxine Holmes, I feel worse a month post-op. That can happen. That can happen. I would say check your labs at 1 month, right, Maxine? If your you may need more supplementation. You may need magnesium. Check your labs. Make sure you're getting appropriate supplementation. If your numbers are normal, right? Sometimes people get a drop in their calcium and they get a PTH that goes sky high, and they have hungry bone syndrome, and that high PTH gives them lots of awful symptoms, right? So check your labs even at 1 month. See if you need to supplement differently. All right. Hopefully that'll rectify it for you. Tammy McGough Stansbury, which time zone? California. Tammy McGough Stansbury. I am wondering this too. Pacifics. Okay. Rosalind House. I'm not sure what to do. Terrified. I've had this problem for about 15 years. Parathyroid hormone is 75. Calcium raised a bit on higher side. Taking vitamin D, not diagnosed with osteoporosis of the left wrist. Been going through menopause for the past well over 20 years. Endo said osteo caused by menopause. I'm very confused. Well, listen. Osteo can be caused by menopause, but it can also be caused by elevated PTH, right? If you have osteoporosis and your calcium is high normal, Rosalind, and your PTH is elevated, then you have hyperparathyroidism, and you have two factors, both menopause and hyperparathyroidism causing your osteoporosis. Find a good surgeon, right? If an endocrinologist recommends you to go to a surgeon, definitely take them up on it, because their likelihood to recommend surgery is the threshold is much lower. Okay, don't be afraid of surgery. This is not a difficult surgery. In majority of cases, I'd say probably in about 90% of the cases, this is actually a fairly straightforward surgery. So don't be afraid. Move on. You'll feel better. You feel like your younger self again. It's totally worth it. All right, pursue it, dear. Jenny Hargreaves. Connection between lupus and hyperparathyroidism, please, and how to investigate a diagnostic test. Any complication with actual tests when the markers show a high negative. That makes sense. I have 3.5 parathyroids taken out, and I don't feel any better, and more symptoms are showing up, nasal abscess being one. Okay. All right. There's no connection between lupus and hyperparathyroidism, except some of their symptoms are similar, right? So the symptoms are similar. One condition doesn't cause the other. Condition doesn't lead to the other one, and they don't necessarily happen together at the same time. They may happen at the same time, but I haven't seen a correlation at all, right? If you had a 3.5 gland parathyroidectomy, I would have to look at your labs to see, Jenny, what's going on with you. And because those labs are going to tell us what's going on, because one of the problems that happens with hyperparathyroidism is that anywhere between 3 to 20% of people have 5 or more parathyroid glands. That's because when the parathyroids migrate from your throat to come down, sometimes they leave pieces behind. So this person has 1, 2, 3, 4, 5 parathyroids. And if this person had hyperplasia and they removed 1, 2, 3, and half of this gland, this person would still have 1.5 gland left, which may be still overworking. So your labs are going to tell us if you still have persistent hyperparathyroidism and you need that addressed. Okay? So don't give up. Keep at it, my dear. Layla Jha. Dr. Larian, I'm 74 years old and live in Australia. I've been diagnosed with hyperparathyroidism since 2011. I've had venous sampling, PET scan, 4D, nuclear scan, FHH, ultrasound, and 3 surgeries. by a very competent surgeon, which have failed to find my adenoma. I'm now in the too hard basket. My PTH is normal, but my calcium levels have always been high, around 2.8, 2.9. I've been told to have a yearly ultrasound if anything shows up. I've also had kidney stones and osteoporosis. Do you have any suggestions, or is this something I just have to live with? Layla, I would say that you should try Sensipar or Cinacalcet. That's a medication that brings down your PTH and therefore your calcium level. If you're not having success with your surgeries and finding the abnormal parathyroid, despite it looks like you've done all the scans in the world, I also would love to see both your operative reports for your 3 surgeries and your pathology reports to see what they found, to give you a better idea, right? But Sensipar or Cinacalcet, which are the same, 2 different names for the same medication, is a good idea because that will suppress your parathyroid system. I think at this point that may be the best thing to do, and then you may also have to take osteoporosis medication to improve your bone density. Good luck, my dear. This is a very tough situation to be. Marianne Wasp. Hi, Dr. Larian. Thank you for your help. My pleasure. Your live is 3 a.m. for me in Australia. I'm 70, diagnosed with hyperplasia in 2019 and had 3.25 gland removed. Previously had kidney stones and osteoporosis. My PTH has only been normal once post-surgery in 2019 and has remained high ever since. Calcium, vitamin D are normal. I have fatigue and insomnia. I've not been back to the surgeon since, but my GP has had me on Prolia injections for the last 2 years. Do I need another surgery, or will this just keep happening? You have 2 options, Marianne. One is to see your surgeon again, see if they can look. Maybe potentially you have 5 parathyroids, like Layla potentially may have, in which case they'll find it and try to address it. Or you may also decide to take Cinacalcet. Sorry about the doctor's handwriting, which is a medication which will bring down your calcium and PTH. And it's a pretty benign medication with very little side effect profile. So those are your 2 options, Marianne. Ask your primary doctor, but definitely see the endocrinologist. Definitely see your surgeon, right? I think the surgeon no longer needs the endocrinologist to figure out what to do. Okay, do that. Burnt weenie sandwich. Okay, I had surgery to remove 2 cancerous parathyroid tumors in 2023. My health has improved tremendously. However, I still deal with brain fog and fatigue. Is this to be expected? If so, what can I do to manage these symptoms? Well, I'm so happy that you are here with us. Burnt weenie sandwich. Parathyroid cancers can be aggressive, so I'm glad you took him out. I don't think I've seen 2 cancers at the same time, so I would question that. I would say I would have to see your numbers now to see if your brain fog and fatigue are related to a parathyroid issue, because you may have had parathyroid hyperplasia and then on top of it a cancer, right? In which case you may still persistently have hyperparathyroidism, okay? And so I would have to see your labs, my friend, to be able to better help you. Danik D10. Yes, diagnosed, no treatment or mention of surgery. Debilitating weakness is only getting worse. Thank you for your in-depth info, my pleasure. But hey, push, Danik D. Don't give up. Get the worksheet out. Write down your information on there. Download it from my website. Use it. Push until you get treated. Okay, don't give up. And you may have to directly go to a parathyroid surgeon rather than a GP or an endocrinologist to get to that point, okay? But don't give up. Pollinap XO. After my parathyroid surgery, 8 months later, my PTH is 86. Calcium is low at 8.7. What are my options? I understand I might have a secondary parathyroid adenoma, but if calcium is low, do I still have the damage to my body? Well, if your calcium is low persistently, it is appropriate for your PTH to be high. So what you may have is hungry bone syndrome, where your parathyroid. So, if you have hyperparathyroidism and you have high PTHs, right? And you constantly lose bone and you now have bone loss and your bone has osteopenia or osteoporosis or less calcium than it should, after the parathyroid tumor has been removed, right? After this tumor has been removed and your PTH numbers now come down in the normal range, your bone wants to take that calcium back, right? So it fights, it grabs the calcium as much as it can from your bloodstream to replenish itself, right? And that's going to cause low blood calcium, which then the normal parathyroids, this one is gone now, right? The normal parathyroids will react by producing more PTH, right? And then a battle ensues. So you may actually have hungry bone syndrome. This high PTH is going to give you symptoms. Probably half of the symptoms from hyperparathyroidism is caused by PTH and the other half by the high calciums, right? So you will feel terrible, but it sounds to me like you have a hungry bone syndrome situation, right? And you need more calcium and vitamin D and vitamin K2 supplementation. Shehla 786, I have a thyroid nodule and parathyroid adenoma. Can both surgeries be done at the same time? Absolutely. I'm currently on cinacalcet to get calcium levels down. I'm waiting for surgery. Will my body be damaged further with this prolonged waiting time? You're going to have more bone loss, Shailajan. And you know, yes, the NHS has its prolonged waiting times. Our healthcare in the U.S. is in shambles and costing. I think the U.S. healthcare system costs as much as the rest of the world's healthcare system put together. Some crazy number like that. Like, we spend $3 trillion on healthcare, the rest of the world spends $3 trillion on healthcare. And we still have a portion of our population uninsured, underinsured, and don't have access to care, right? So I don't know the perfect system yet, but we have to get there, right? We do. Anyways, yes, waiting longer is going to have more bone loss and you're going to have more symptoms. But if waiting is 4 months, 5 months, that's not an issue. If it's 2 years, that's an issue, right? So, and cinacalcet does help. It doesn't take away all the issues, but it does temporize things. So good luck, my dear. But yes, both of them should be done at the same time. It makes no sense for you not to remove not to address the thyroid nodule at the same time. I usually when I'm doing parathyroid surgery, if my patient has a thyroid nodule that I find on ultrasound, let's say the day before surgery, I'll do an ultrasound and I see the parathyroid, and then I also see a thyroid nodule, right? During surgery, I may just go and remove just that nodule. So this whole thing is a thyroid gland. I may just go in there and just remove this nodule so that it doesn't grow in time. If I'm already there, if I'm already right next to it, I've made the incision, I would just come underneath to get to this parathyroid. I can easily get to that and just take that out and leave the rest of the thyroid intact, okay? So that's what I would suggest. Shella says, waiting over a year for surgery. Well, again, hopefully you don't have too much longer to wait. If it is going to take a few more years, then you may consider doing the surgery elsewhere. You can come to the U.S. I get patients from Canada, England, and the rest of Europe on a regular basis, right? I rarely get patients from China. The other East Asian countries I do get patients from, as well as Middle East, and infrequently from Africa as well. So, you know, you have other options, my dear. Dylan, have you ever seen a young onset case with an ectopic parathyroid gland within the left retropharyngeal space? What would your approach be? how would this differ to the usual approach? What questions should be asked to the surgeon before surgery? Well, if it's retropharyngeal, that means your parathyroid is, okay, so the pharynx is, let me draw on this. So if you look at the mouth, this is the tongue that comes to the voice box. This whole thing is the tongue, right? It comes to the area right above the voice box, okay? And the pharynx is the throat here, so that this space where the food comes down, and the esophagus is the tube behind this breathing tube and thyroid, okay? So if your parathyroid tumor is retropharynx, it means your parathyroid tumor is back here somewhere. So an incision in the lower neck is not going to get there, right? So if it's high up, you can potentially approach it through the mouth and get it. If it's lower and you can't get it through the mouth, then you have to make an incision in the upper neck, or maybe even on the side of the upper neck to get to it. So you need probably an ear, nose, and throat surgeon that does parathyroid surgery. So find an ENT that has expertise. I'm an ENT that does this. That's why I say it. So the unusual parathyroids, for example, this is an unusual parathyroid. That was, so this, in this image you can see this is the neck. The thyroid would be the green area. So the thyroid would be in the lower neck, as this image shows. This particular parathyroid is up here, right? This is it. And it's all the way deep to the jawbone. So this here is where the jawbone would be. Okay? And the parathyroid is just deep to it, right? So it's next to the pharynx. It's not retropharynx, it's parapharyngeal. This is the parapharyngeal space that it's in. And this is the surgery. Oh. Going all the way up, and there it is. And you can see the pulsations. This is the carotid artery in the bottom here. Oh. And the parathyroid is at the deep end, and this is the parathyroid. This is the nerve that goes to the tongue. It was in the sheath covering that, so you can see the nerve going to the tongue here, and the parathyroid that has been removed. Right? So yes, yeah, I've seen it. The approach is different. You can see in here, this, I don't know if you can see this. This is the person's chin, neck. This is the back of the neck, and this is the head. This here is the earlobe. So the incision is there to get to that. Okay? So the approach has to be different. It has to be someone who has experience operating in these spaces. Kimberly, is hyperparathyroidism the only thing that can cause high calcium and PTH levels? Could other illnesses like sarcoidosis causes an elevation in calcium, not PTH, because sarcoidosis produces a vitamin D-like substance, right? So sarcoidosis is one of the, good question, it's one of the elements that gives you high calcium. So sarcoidosis can cause high calcium. Then you have medications. The medications that can cause high calcium are these. Okay? So, no, nifedipine or calcium blockers don't cause hypercalcemia, hypercalciuria, or high PTH numbers. No. Okay? So, this sarcoidosis could cause hypercalcemia, and then, of course, the other table here, which causes things that cause high PTH numbers. Okay? And we've looked at that multiple times. Ivan or Lynn Ann have an appointment with January with endocrine for hyperparathyroidism and osteoporosis. What pre-imaging or additional labs would be helpful prior to my provider is happy to order whatever is needed. Okay, Lynn Ann, go to the website and download this worksheet. The second page, this has your symptoms which you can mark off, but on the second page it has a list of labs to get. All right? So if your calcium and PTH are both elevated, then all you need is calcium, PTH, vitamin D, fasting, and at 8 o'clock in the morning. If these two are elevated and this one is normal, vitamin D is normal, right? Then you have hyperparathyroidism, right? That's clear diagnosis. I would do an ultrasound of the neck, and they have to put diagnosis hyperparathyroidism. So the ultrasound tech looks for a parathyroid. If you just say neck, they may not look for a parathyroid. Okay, and those would be it. Good luck, Lenan. Michelle Purcell. How do you feel immediately following surgery, especially when multiple glands are expected to be removed? The only thing that reliably gets better after surgery is bone pain. Everything else will take time. The longer you've had the hyperparathyroidism, the longer it will take for you to feel better. Okay? So, outside of the bone pain, there's nothing else that I can tell you reliably will get better, and I can't give you the time span. All right? The bone pain will, in recovery room, will feel better. Okay? And most other things, I do surveys for 4 years after the surgery, and I find that everybody has improvement. You know, continuing to 2 years, some even up to 4 years. So there's, you know, you'll do better regardless. Sammy 9116 had total thyroidectomy due to thyroid cancer. Now got primary parathyroid, waiting for surgery. Only got 2 parathyroids. Both got adenoma. Got osteoporosis. Is a good idea to have surgery. How could it affect life after with no parathyroid? Well, no, it can't take out all your parathyroids, Sammy. They'll probably, if 2 of your parathyroids, listen. If during your total thyroidectomy 2 of your parathyroids were removed and you have 2 parathyroids left and both are abnormal, then 1 or 1.5 of those will be removed, not both of them. There's no reason to leave both. I mean, take both out, because if you do, then you have to take high doses of calcium and vitamin E. You'll be fine, right? Most likely you'll be fine, but the best thing to do is to remove 1.5. SFD cup fan, okay? I'm 58, 5 feet 7 inches, and trying to remove above 112 pounds. My lowest weight is so I had a DEXA scan which showed osteoporosis in the neck of my left hip, which resulted in a visit with a rheumatologist. Blood test showed high PTH. Everything else was normal, but a visit to the rheumatologist resulted in hyperparathyroidism diagnosis. Despite normal calcium after the 24-hour urine test. Always normal calcium. I'm vegan, and that's not changing. I lift and do yoga regularly. Last blood test shows PTH is 92, GFR is 53. Okay, now I'm worrying because this is a new problem that I understand is connected to hyperparathyroidism. So I don't know anymore. I can't gain and hold weight. I'm considering a 72-hour fast to maybe reset everything. My endocrinologist left the hospital. I'm in an appointment to hopefully get my next scan. Then I'll make an appointment with you if you'd accept a new patient from Michigan. Okay. Well, Sammy, I'm happy to accept you, and I can do a Zoom consult for you. That's not a problem. I do Zoom consult from people all around the world. All right. But I would need to see your calcium, PTH, and vitamin D numbers and your 24-hour urine calcium. And then I would suggest doing an ultrasound, and then you can contact my office, and then we can do a Zoom consult for you. With those, I can help you, guide you, and let you know what the next best thing to do is, okay? All right. Sean Iglasco. I'm a 62-year-old female, 150 pounds, after suffering with all the symptoms you talked about in your videos, and I've been diagnosed with secondary hyperparathyroidism with renal by a kidney doctor in August 2020. Currently seeing him yearly. I asked for a referral to an endocrinologist. Hasn't happened yet. Kidney doctor wants PCP to do it. She has not. So I changed doctors, still no referral. Currently taking vitamin D3 and K2 to keep my PTH in a normal range. I'm left to figure out how to take care of myself. I'm worried about my kidneys. I also have sleep apnea, central obstructive, high cholesterol. Sometimes my blood pressure is high and my glucose is low. I'm worried something else is going on with my body. What should I expect with this secondary hyperparathyroidism? How do I get an endocrinologist without a referral? What kind of imaging do I need? You don't need a referral to see an endocrinologist. You can just call their office and make an appointment. Okay? Private practice endocrinologists, majority of them, you just call and make an appointment and you can just go in there. You don't necessarily need a referral. Referrals are usually in the closed system, in the university setting, or like Kaiser or an HMO setting. In a private practice setting, you don't necessarily need that. But if you're having a hard time getting all this, contact my office and I'll look at your numbers and guide you as to what you need to do next. Okay? But as of October 2025, you wrote calcium is 10.0. Great. PTH is 51. So your calcium is high normal, PTH is high normal. That's not normal, right? Vitamin D is 63, and your GFR is 63, so it's not so low. So this is not the reason why your PTH is high. You have hyperparathyroidism, all right? The problem is that your calcium and PTH numbers are, although abnormal because they're not inverse of each other, they're in the normal range. So in this scenario, what I would do is I would do 3 sets of labs and have your primary doctor order that. Calcium, PTH, vitamin D, fasting, and at 8 o'clock in the morning. Make sure you're not taking any biotin or any blood pressure diuretic medication, right? And you do it consistently in the same lab at the same time, 8 o'clock in the morning. You don't do it later or earlier than that. And then once you have those numbers, then you can see the trending, and then you can come up with an answer. Don't go to an endocrinologist before that. Go in with having had 3 sets of labs under these conditions we talked about. All right, my dear? Good luck, and I'm happy to help you if you need me to. All right, done with the questions that came in advance. Let's take a look at the questions that have come in during the session. Oh, whoa, there's a lot. Okay, very good. Let's see. D11NZ4. What would your opinion be on an ectopic parathyroid gland within the left retropharyngeal space, very high in the neck, found from a 4D CT scan in a 23-year-old patient with negative genetic testing? Well, I think we talked about that. If you have hyperparathyroidism, especially if you're young, you got to treat it, because otherwise you're going to get all sorts of symptoms that may become permanent, right? And so I just showed you the video of how I took out parapharyngeal space and retropharyngeal space tumors is roughly the same. Some are easier to address Some are a little bit more difficult, but in a 23-year-old neck that is healthy, not a difficult surgery. Not at all. Not a difficult. You just want to find an ENT surgeon that is doing surgeries in that space, okay? That does parathyroid surgeries routinely and does PTH testing. Good luck, my dear. Emily Beasley, can you elaborate on inappropriate normal PTH and high calcium? Just had a negative sesame B scan yesterday. So that what you're talking about is normal hormonal hyperparathyroidism. Okay, so a normal hormonal hyperparathyroid patient is this. Calcium is elevated, but PTH is in the normal range, right? In these patients, you have to do a full workup of all the other causes of high calcium, right? Not hard to do. These are the other causes of hypercalcemia, right? Should be worked out. And I usually check a 24-hour urine calcium as a further thing. I do bone density studies to see where I stand with that. I'm not a big fan of the sesame B scan, which you're saying you had yesterday. Just had a negative sesame. Yes, the sesame B scan is not a scan of parathyroid per se. It's a scan that concentrates and is attracted to the engine of cells. So cells that have are revving high, right? Like heart muscles. We do a sesame B scan on heart muscles to see if there's parts of the heart that are dead and are not picking up sesame B, right? The salivary glands accumulate sesame B. Active thyroid nodules, some of the other things in the neck pick up the sesame B. Because it's not specific to parathyroids, it becomes hard. And because it's specific to the engine inside a cell, not necessarily a parathyroid, then it can be misleading, all right? I found that people who have, there's a study that came, I think it was out of Hopkins or Geisinger health system, that looked at the accuracy of a sesame B scan as it relates to PTH level. So when the PTH was above 150, the sesame B scan was accurate only 84%, I think 84.6%. When the PTH levels were less than 100, it was only 50% accurate, right? So I rarely use sesame B scans. So the fact that the sesame B is negative is not unusual when you have low hormones, right? I would start with an ultrasound. If that doesn't work, I would do a 4D parathyroid CT scan, okay? And the people who have this are more sensitive to PTH. So even though the normal range of PTH in the laboratory is 15 to 65, for this particular person, their range of normal may be 5 to 25. And a 52 may be double their particular normal, right? So that's the explanation. Nancy Lindsay, a few of us are waiting on Facebook. Okay, no problem. Nancy, okay. Volume a bit low. Sorry. I had 3 parathyroids removed. This is Teresa Atkinson. I had 3 parathyroids removed, 1 tumor and 2 hyperplasia. What are the chances of a 4th gland going bad? If you had 3 removed and 2 of them were hyperplasia, then more than likely that 4th gland also is hyperplastic. Hopefully it's small enough that in your lifetime it doesn't get the chance to grow large enough to get you in trouble. But I would monitor your calcium, PTH, and vitamin D every year with your annual exam. If you get symptoms, maybe do it sooner. Shah Mas, thank you, Dr. Larian. I've got a question. In a fit, asymptomatic patient with only mildly elevated calcium, below 11.4. Vitamin D at the lower end of reference range, but not optimized. Normal renal function, no symptoms of hypercalcemia, and not localizing imaging. Would you recommend parathyroid surgery before correcting the vitamin D deficiency and reassessing the PTH level. Okay, so I would try to optimize and see, in my mind, when people, okay, high calcium levels are not caused by low vitamin D, all right? They can be caused by taking too many calciums, right? It can happen in people who are taking too many Tums or too many calcium supplements. It can happen by vitamin D intoxication, taking too much vitamin D, but it's not caused by low vitamin D intake. So it is unlikely that you're going to have a high calcium if your vitamin D is low. Okay? So if your vitamin D is low and your calcium is high and your PTH is high, then you have hyperparathyroidism. You can take the vitamin D to help protect your bones and see if that brings the numbers down a little bit, but it won't correct the hyperparathyroidism, right? So if you have hyperparathyroidism and you're fit and healthy and you have zero symptoms that affect the quality of your life, right? So if you have none of these symptoms, okay, then what you need to do is a bone density study to see if you have osteoporosis. You need to do this, basically, you need to do an extensive workup to prove to yourself that you do not have a reason to have surgery. So you check your labs, which you've done, bone density study, knowing that bone density doesn't show the spine well, then you may have to do other tests for the spine, X-ray, CT scan of the bone, or a VFA, get the 24-hour urine calcium, abdominal X-rays and CT scans to make sure you don't have any kidney stones, look at your bone markers to make sure you're not losing bone, and so on. So I would do an extensive workup to prove to yourself you don't need it. And you may not, Sean, right? But prove to yourself that you don't need it, rather than wait for it to get you in trouble. All right, Marianne Collins. I'm having surgery next week. What should I expect after one adenoma, lower left, one lower right nodule? Not sure what that means. Endocrinologist recommends vitamin D 800 to take daily. I also take magnesium daily. Should I stop now as surgery 7 days? No, continue. Definitely continue the vitamin D. Yeah, I can continue the magnesium and take calcium after surgery to replenish your bones that have bone loss, right? Again, I showed earlier. I showed the chart that I used for vitamin D and calcium supplementation, and then in terms of what to expect, again, bone pain will go away right away, and everything else will take time. I suggest that you be active after surgery. Your surgeon will let you know when they expect you to be okay to be very active, but be active, force the rebalancing of the calcium, do memory games and brain challenges and mental challenges so that you can force your brain to adapt and get better and your body to adapt and get better, okay? Lisa Phelps, I'm 11 months post-op, 2 tumors removed, and my other 2 never turned on. PTH is fine. Oh, you had bilateral exploration. And therein lies the problem with bilateral explorations. When you do bilateral exploration, sometimes you can damage the other 2 glands and they'll never regain function and you'll be permanently hyperparathyroid. I'm so sorry, Lisa Phelps. Now, I have seen it take longer than a year to recover, so there's still hope, okay? So you're taking calcitriol, 1 microgram of calcitriol a day, and 1800 milligram calcium citrate to. Well, your calcium doesn't need to be that high. Your calcium is 10.2 with these supplementations. You're taking too much, right? You may want to go lower on the calcitriol, right? My general dose is 0.25 micrograms twice a day, which adds up to 0.5 micrograms. You're taking twice that dose, right? 1800 calcium citrate is okay. So you may want, because calcitriol suppresses PTH, right? So if your calcium in your blood is 10.2, that means you're absorbing way too much calcium. You're taking too much calcium, you're absorbing too much calcium, don't need as much calcitriol, your parathyroid glands are suppressed. It's not a surprise that your PTH still stays low. So you need to adjust that and talk with your endocrinologist to adjust that, okay? Your calcium should not be at 10.2. They should be in the normal range. Normal range is 8.8 to 10.2, but bring it lower, bring it in the lower 9s, right? And then that'll help the parathyroids remaining not be super. At the calcium of 10.2 with this much calcitriol, your parathyroid glands have no reason to work. You're doing all the work for them. Good luck. Janice Heffernan Warnament. Is this recorded to watch later? Yes, it is. What causes tertiary hyperparathyroidism? Could it be persistent low vitamin D? Sean, we went through it. Yes. I mean, you'd have to have it for an extensive period of time to get you to the point where you get tertiary from low vitamin D itself. Generally seen in the setting of kidney failure and people who are on dialysis. Emily Beasley, can you please elaborate on it? Yeah, we talked about that. Okay, Sean Iglasco. How realistic is maintaining this secondary hyperparathyroidism renal with vitamin D3 and K2 and not getting worse? It really depends on the severity. I mean, if your kidney function is enough to make let me show you. If your kidney is functioning enough to have enough of this enzyme to change your inactive vitamin D to active, then your kidney malfunction is not causing hyperparathyroidism, right? So you have to check this lab. So when normal vitamin D labs show this particular lab is activated vitamin D, right? And this is not normally done. Do this. That gives you a more realistic idea of where your kidney malfunction is contributing to your hyperparathyroidism, okay? Nicole Lepage, if your parathyroid is low, what is the common cause? Well, if it's persistently low, it could be that you have one of the reasons to get hypercalcemia. So if you have any of these conditions, not hyperparathyroidism, then your calcium will be high and your PTH will be low, all right? Or if you have autoimmune, the most common cause of non-thyroid surgery induced hypoparathyroidism is autoimmune hypoparathyroidism. Jessica Morrison, hi. Replying to Emily Beasley, I would like to hear more info on inappropriately high PTH and high calcium. Well, if you have high calcium and you have high PTH, then you have hyperparathyroidism, right? Because in a normal parathyroid environment, let me show you. So this graph is looking at PTH as a percent of maximum. This graph is looking at PTH as it relates to concentration of, and this side is calcium, right? This whole thing is calcium. So if you look in a normal parathyroid environment, you're following this graph, right? So if your calcium is high, normal, your PTH should be very low, right? If your calcium is low normal, your PTH should be high, right? When someone has hyperparathyroidism, they follow this graph, another graph, depending on the setting of the tumor. This one is set for 11, right? So for someone who has a tumor set for 11, your calcium is high and your PTH is still high, right? And that shouldn't be, because in a normal parathyroid environment, if your calcium is 11.1, your PTH should be close to 0, right? So that's what we say about when we say inappropriate. Your calcium is high, your PTH should be really, really low, right? And it's inappropriate for it to even the high normal. And you have to look at that consistently. Look at the labs multiple times, okay? Jessica, I hope that answers your question. Nancy Lindsay says, I wonder if I should push to have these tests done at our university hospital. Yes, please. And then she said, you said 2 weeks for thyroid diuretics? Yes, 2 weeks. Hold for 2 weeks before doing blood tests. Serenity Z2W. Stone, bones, and Crohn's is something I should pay to go private cause the NHS are taking their time. Yes. I mean, if the NHS, which is the UK healthcare system, is not addressing your disease and you're getting worse and you're feeling awful and you can't get to your daily life and manage your life, then yes, please take action. Marian Collins, how about vitamin D 800? Also magnesium prior to surgery. I don't give magnesium to my patients prior to surgery, but I definitely do give vitamin D. Terry Tyler Eddy, surgery on December 5th. Will the headaches go away? Well, it depends on the cause of your headaches. Yes, hyperparathyroidism can cause headaches, and if it's caused by it, yes. If you have migraines, frequency of migraines increases in a hyperparathyroid state. Serenity Z2V says, never mind, this isn't live apparently. Yes, it is. Yes, it is live. I just hadn't gotten to it. I was going through the questions that came the day before. Nancy Lindsay, this is live at 10:01 Pacific Standard Time. Okay. And Johnson, what effect does low alkaline phosphatase have on hyperparathyroidism? It doesn't affect hyperparathyroidism, but if you have low alkaline, generally it causes high alkaline phosphatase, right? Because when bones are losing calcium, they also release alkaline phosphatase. And then you say, I'm waiting on a nuclear scan to check for my parathyroid glands. And Johnson, I recommend that you do an ultrasound and a 4D CT scan before the nuclear scan. Maggie MC says, thank you for responding earlier. Some of my earlier results. How do I calculate my calcium set point? There's no way for you to calculate your set point. If you have labs from 20 years ago, right, that shows your calcium was hovering, let's say, 9.2, 9.3, 9.1, 9.2, then you can estimate that your set point was somewhere around those low nines, okay? But otherwise, you cannot. So Robert DeBella says, oh, hi Robert. After my surgery, my bone pain went away immediately. The brain fog, a little after my surgery. The mood swing, irritability didn't subside until 5 to 6 months after. Robert, thank you so much for sharing this. This is so great. It's so great to hear from you still, and it's so great that you're doing better, and so great that you're sharing this. All right? Please, more of you who've had surgery, share your experience so everybody else knows. Ginny Laurie, I'm 1.5 years out and had normal kidney labs prior to surgery. Now my creatinine is up to 1.7, normal beyond. GFR is less than 50. Can this be related to surgery? Unlikely. If you had a successful surgery, it shouldn't be related to that, right? Decreasing the calcium load on the kidney actually should help. So there's something else going on. Please see a kidney doctor and have him do a full workup. Shama says, I've done all 3 scans except PET scan and nothing's come up. I'm well and asymptomatic, but with only mildly elevated calcium, vitamin D at the lower end of reference range, but not optimized, no normal renal function, no symptoms of hypercalcium. Would you recommend parathyroid surgery? Sean, again, I would do bone density studies to see if your bones are healthy. I would do scans of the kidney to make sure you don't have any kidney stones. Make sure your kidney function is totally normal, which you just said it was. And if those are all negative, then you can potentially wait. If any of those are off, then proceed with surgery. All right, guys. Unfortunately, there's a few more questions that I'm not going to be able to get to. I have patients I got to run and see. I had a parathyroid surgery later today. Anyways, thank you so much for the interesting questions. Thank you for challenging me. Thank you for making me think, and thank you for sharing. Best of luck to all of you who are in the process of discovering and identifying your illness and potentially getting treatment. If I can be of any help, please don't hesitate to contact me. Have a wonderful day, wonderful week, wonderful holiday season. Take good care. Bye.